of the cases from the Ocean Road Cancer Institute are diagnosed at stage 3 or 4, very advanced stages at diagnosis, and about 50% of the tumors are ER negative, PR negative in Tanzania. So in summary, we see variable incidence of breast cancer in the Middle East and Africa. We see increasing incidence and differences between rural and urban areas, possibly due to environmental exposures. We see downstaging in some countries, probably because of more awareness about medical care and the need to go for medical care. We see also high incidence of ER positive tumors in urban areas, possibly due to xenoestrogen exposures. We studied a high proportion of IBC in North Africa. We are trying to find distinct molecular and pathologic characteristics of the disease to diagnose the cases and understand the epidemiology of environmental exposures and possibly infectious agents that may modulate the disease presentation and risk. And we highlight the importance for understanding the international differences in breast cancer incidence, inflammatory breast cancer, and try to understand what we learned from this experience to disseminate it to Arab populations in the US. The challenges that we face in these types of international studies is building the international team and having an infrastructure for research. Also, the data representation of our research. Population-based cancer registries are very limited in the Middle East. We don't expect that we're going to find population-based cancer registry in every single country. We are trying to maximize the opportunities of working with hospitals and using hospital registries for research. There is a need for standardization of clinical criteria for diagnosis. When we talk about inflammatory breast cancer or other diseases, we need to standardize the clinical criteria so we can compare cases from different countries. There are different issues, cultural and logistical issues for joint research collaborations that we are learning as we go with this experience. Currently,